Okay guys, good morning. We are with the second video of ACLS. This is about tachyarrhythmias and bradyarrhythmias. Okay, so what we'll see in tachycardia, basically in ACLS, we see a patient with blood pressure, and we see a patient with maybe a low blood pressure or a high blood pressure, but pulse rate is important. Okay, the heart rate should be more than 150 per minute, so we'll see a case of tachyarrhythmias. What happens in bradyarrhythmias? Bradyarrhythmias, we see a patient with a heart rate less than 50 minutes. Now see, a heart rate more than 150 and less than 50 is the bradyarrhythmias, and this is the tachyarrhythmias. In the bradyarrhythmias, we have AV blocks and sinus bradycardia, right? These are the differentials. In the tachyarrhythmias, we have sinus tachycardia, we have atrial fibrillation, we have atrial flutter. Okay, tachyarrhythmias, we have ventricular fibrillation. Okay, we have ventricular tachycardias. In the ventricular tachycardias, we have monomorphic VTs. It looks like a finger. Okay, and these are same shape, right? And we have polymorphic VT. We have a different shape and size waves. Okay, and we have something like this. Okay, this is torsades de pointes. This is torsades de pointes. Okay, the treatment here is magnesium, very important. Now we have seen tachyarrhythmias, we have seen bradyarrhythmias. Okay, in the bradyarrhythmias, what we see is AV block and sinus bradycardia. Now here you'll see in the sinus rhythm, there is something called sinus rhythm, right? Normal sinus rhythm, right? So there is a PQRS waves, right? Now we count the RR waves and we count the heart rate, right? Now what happens in sinus bradycardia? It will be slower, and in sinus tachycardia it will be faster. The RR interval will be less in sinus tachycardia, and RR interval will be more in sinus bradycardia. Now identifying AV block is very important. So AV block, what we see first is very important. Is there are two things what we see. First is RR interval. Is it regular or irregular? Okay, now if it is regular, it will be only primary AV block, or it may be tertiary AV block. If it is irregular, it may be second degree type 1, or it may be second degree type 2. So the first thing what we see is RR waves, what we see is regular or irregularly coming. Okay, so if it is irregular, it is primary or tertiary. It is irregular, it is second degree second degree type 1, that is Wenckebach, and second degree type 2. Okay, now what we see next is the PR interval. Same or not? If it is yes, it is same, then it is primary. If it is not same, then it is AV dissociation, that is the tertiary heart block. Okay, now again, if it is if the PR interval is not same, it is second degree type 1, and if it is same, it is second degree type 2. Okay, so this is how you see the AV blocks. So RR interval we see, if it is regular, then it is primary or tertiary. If it is the third degree, okay, first degree or third degree. If it is irregular, it is second degree type 1 Wenckebach, or second degree type 2, right? Now if we see the PR interval, we see the PR interval. You see, now this is the PR interval. If it is increased, it shows a block in the AV node, right? So it is the time taken for the electrical rhythm to pass the this is the SA node, this is the AV node, right? Now the time taken to pass this gap junctions present in the AV node area is the PR interval, right? If it is increased, it shows a block. So the types of block I've showed you and how to identify the types of block. Okay, so this is very important to identify the types of block. Okay, so these are bradyarrhythmias, and then the tachyarrhythmias you have seen sinus tachycardia. Ventricular fibrillation is very important. Atrial fibrillation is also important. Atrial flutter is important. How you will identify flutter waves? It will be sawtooth appearance. So ECG I have discussed in a separate video. Please go through it. ECG, you can see, you can just learn about ECGs. Atrial fibrillation, you will get a fibrillatory waves. What do you mean by that? It will fribble. You cannot identify a P wave. In atrial fibrillation, you cannot identify a P wave. Okay, so ventricular fibrillation also similarly this kind of waves. Okay, so ventricular fibrillation, you will get a fibrillatory waves. Okay, Now, important is ventricular tachycardia, supraventricular or ventricular tachycardia. The ventricular tachycardia may be monomorphic, like finger-like appearance, uniform finger-like appearance, right? And polymorphic, there will be uniformity will be lost. Okay, and torsade de pointis, I have told you the treatment is magnesium. Now, the important thing is when we identify a tachyarrhythmia or a bradyarrhythmias, the process is same how you are going to identify and treat the underlying cause. Now these two steps which I am going to discuss right now is similar in both the part. Right? So identify and treat the underlying cause. Whether now first we see is the ABC, right? We maintain a patent airway, assist breathing as necessary, oxygen if hypoxemic, cardiac monitor to identify the rhythm, monitor the blood pressure and oximetry, right? So cardiac monitor we attach, we ask, the patient has came to us, patient is saying sir मेरे को बहुत fatigue लग रहा है, अच्छा नहीं लग रहा है सर, है ना? So what we do, we attach the monitor, we see for the SpO2, we see for the ECG. Okay, now we check the blood pressure, right? So blood pressure will find very less. Okay, and sorry, this is tachycardia. So blood pressure will see higher side, right? In the heart rate also in the higher side we see, right? SpO2 will be maybe less. So if less than 92%, then what we do? 92% we give oxygen at a rate of 3 to 4 liters per minute. Okay, if it is more than 96, we don't give oxygen. Okay, now if I now we have now we can do the patient stable, we can have an access to 2 IV lines. Okay, but in one IV line we can start a slow drip of normal saline if required. If we can increase the flow if it is hypotension, patient complains of hypotension. Okay, and IV access too is important because sometimes the patient can go to cardiac arrest. Okay, and then we have to follow what we have done in the previous video, how to treat a patient with cardiac arrest. Right, now this is important. Now this identifying and obtaining a 12 lead ECG. In the 12 lead ECG you will clearly find the cause of the problem. Okay, now if there is persistent tachyarrhythmias, you will see the cause, you will see the BP, whether its hypotension is present or not. You will see if the patient has an altered mental status. You will see the signs of shock, right? It may be cardiogenic shock, it may be hypovolemic shock, ischemic heart discomfort is there or not, pain is there or not, acute heart failure symptoms are there or not. Now these two things will be present also in the case of bradyarrhythmias, that we maintain a patent airway, the oxygen, the cardiac monitoring, we attach the monitors, IV access we get, 12 lead ECG we get. Now hypotension we have to check whether it is present or not, Okay, now acutely altered mental status is present or not, signs of shock, ischemic chest discomfort, and acute heart failure. These two things will be common in both. What is changes in tachyarrhythmias? In the tachyarrhythmias, if these things will be present, we go for a sync mode in synchronized cardioversion. We goes on synchronized cardioversion. Now suppose this tachyarrhythmias here, the tachyarrhythmias, we actually found this is a case of VT, either monomorphic or polymorphic, or supraventricular tachycardia, SVT. Okay, suppose this kind of patient we came, right? So we are seeing this patient has a BP low and altered mental status. So we go for a yes algorithm and we go for synchronized cardioversion. In this synchronized cardioversion, we use the shock pad and we start from the lowest spot. Okay, but 50. Okay, but we can start from 100. Earlier the guidelines were based on the joules, what kind of things we get, and according to that we have to give the shock. But now now the guidelines tells that you can start with the lowest. Okay, we can start with 100 also in the clinical settings, right? In the theory part we can say that we can start with 50, then 70, then 100, okay, then 150, then 200. So we have to increase the dose, and also we have to sync. So we have to give a synchronized cardioversion. But before doing that, giving synchronized cardioversion, we have to talk to the patient. Very important. Now this step here is a lacking, which we can write over here, that we have to counsel the patient or the patient party. Okay, counseling of the patient is very important. Second, address the problem to the patient. We have to tell to the patient what is the problem, what we are going to do. We have to take consent to the patient from the patient, so that we can get an sedative to the patient and we can give a synchronized cardioversion. So consent is important. And fourth, we have to give sedation. Like around 3 to 4 milligram of midazolam IV and something like that, right? So we have to just give to sedate the patient, and we have to tell the patient कि आपको हल्का सा करंट का झटका लगेगा, आपको उसमें घबराने की ज़रूरत नहीं है, आपका हार्ट बहुत तेज़ बीट कर रहा है, उसको हमको कंट्रोल में लाने के लिए ये करना पड़ रहा है. इस बीच में आपका हार्ट रुक भी सकता है, जिसके लिए हम लोग तैयार है, आपको घबराने की ज़रूरत नहीं है. दिस काइंड ऑफ थिंग्स वी हैव टू मेक द पेशेंट अंडरस्टैंड. ठीक है, एंड देन द कंसेंट. ओके, काउंसलिंग, एंड इम्पॉर्टेंट इज दैट वी हैव टू सिडेट द पेशेंट. ठीक है, सिडेशन. आफ्टर sedation we have to give a synchronized cardioversion. ठीक है. Now if there will be a narrow complex, tachyarrhythmias, we can give adenosine. Wherever we can find a narrow complex, we consider to give adenosine. Now adenosine dose is 6 milligram IV flush, 6 gram IV rapid. Okay, we adenosine has a very short half-life. So adenosine in the left hand we usually give 6 milligram IV, and we flush it with 20 ml NS flush. Okay, and we raise the hand. Okay, so that quickly adenosine goes, and we consider this to be effective. Okay, if adenosine, this dose is not working, we will give double the dose of adenosine. Clear? Now it is very important you to understand that we don't in case of this activities are present, maybe signs of shock, hypotension, or altered mental status, we don't go for anti-arrhythmics. Okay, we just give adenosine if narrow complex is present. Otherwise the treatment of choice is synchronized cardioversion. If it is refractory, not acting properly, now we try to find the underlying causes. Okay, there will be need for increasing the energy of the cardioversion, and then if it is not working, we can give 12 milligram adenosine. Okay, and we can add some antiarrhythmics, but basically we don't add now. But if we add the amiodaron. See, the amiodaron dose in the cardiac arrest was 300 first and then 150. Here the amiodaron IV dose is, starting dose is 150 over 10 minutes. So it is a slow infusion, right? 150 milligram over 10 minutes. This is the slow given, right? Now if repeat it if the ventricular tachycardia recurs, and follow the maintenance infusion as 1 milligram per minute for 6 hours. So 60 milligram in per minute, 60 milligram in 1 hour. So into 6, so it will be 360 milligram in first 6 hours. 360 milligrams in first 6 hours. Okay, we can go for procainamide also. Okay, so 20 to 50 milligram per minute until arrhythmia is suppressed. Okay, and an important thing is that we have to avoid it if the QT is prolonged. Okay, there is a beta blocker, sotalol, right? Potassium channel blocker with beta blocker, right? Now this sotalol we have to give 100 milligram over 5 minutes. Avoid if there is a prolonged QT interval. Okay, now the important thing is that when we are considering synchronized cardioversion, we will increase the shock from the lowest and then we go for higher joules. Okay, so the starting dose, if you'll ask that what I will do when if I'm there in the ICU or emergency, I start with the 100 joules. Okay, because earlier the guidelines were, there were many, but like they have also started from the 100, so we can go for 100. We don't have to start from 50. So now it is important, if there are no such complaints, another patient is having no such complaints of hypotension or signs of shock or ischemic chest discomfort, we'll look for the QRS. The QRS, suppose it is wider. Okay, it is a wide QRS complex. It is a narrow QRS complex. A narrow QRS complex ECG tachyarrhythmias or a wide QRS tachyarrhythmias. Okay, so narrow क्या है, wide क्या है. Okay, now the wide is, we have to give, if regular we have to give adenosine. Please don't confuse. If wide is there, we give directly amiodaron 150 milligram. Okay, if wide is there, we consider amiodaron. एकदम स्ट्रेट कंसेप्ट है, कोई कंफ्यूजन नहीं होना चाहिए. वाइड क्यूआरएस कॉम्प्लेक्स आपको दिख रहा है, आप एम्योडारॉन 150 मिलीग्राम चला दीजिए. अगर नैरो है, देन गो फॉर वेगल मैन्यूवर्स. ठीक है, वी मसाज द वेगस, राइट. वी गिव एडिनोसिन if it is regular. Yes, it is written over here that adenosine can be given if regular and monomorphic, but I recommend that if you see a wide QRS, go for amiodaron first, and then you can give adenosine if you understand that that is a patient with a regular tachyarrhythmias. But first you have to give amiodaron. That is very, very important. Okay, but if case of narrow QRS complex, we give vagal maneuvers, very, very important. Then adenosine and beta blocker. And please, if you don't understand what is going on during your when the patient is there, please ask for expert consultation. And please, in many fields we have seen that people don't talk to doctors because of some inferiority complex, or maybe they don't want to feel in that way. So I believe if you don't understand what the patient is actually having, you just ask for help. Okay, you just ask for help, you ask for expert consultation. Okay, you ask your team if the team can help, right? Okay, so this is very important. This was the adult tachycardia with pulse algorithm. Pulse is present. If a pulse is absent, what we will do? If the pulse is absent, we'll start directly with the, if suppose in the doing a tachyarrhythmias management, the patient suddenly has no pulse and patient get having no pulse and patient is unconscious, right? Those will start with the CPR as soon as possible. The monitors are attached. We'll see the rhythm is shockable or not, and then we'll go as the process was there. If the rhythm is not shockable, then again we'll give epinephrine and we'll start CPR. If it is a VF or PV pulseless VT, then we'll start with the giving shock, then CPR, IV access, shockable or not, then CPR again, epinephrine, capnography will see. Okay, we discussed the underlying reversible causes, shockable or not. Then first shock we give epinephrine, second shock we give amiodarone 300 milligram bolus. Okay, but here what we have seen that we consider amiodarone if there is a wide QRS complex, and we give an amiodarone dose of 150 milligram over 10 minutes. It's not bolus. Okay, this is a basic difference we have to understand when we are treating tachyarrhythmias and the cardiac arrest. Okay, now we'll just go for the bradycardia algorithm. It's very simple. Okay, so these things are very common. These things are common. If these things are not present, okay, if these things are not present, we just monitor and observe the patient. Okay, if there is a hypotension, then we give for IV. Right now, the basic thing we have to understand that any bradyarrhythmias, any bradycardia, or if it's an AV block, if we can see the patient heart rate is around 40 per minute, 30 per minute, or even decreasing rate, right, the patient will directly go to cardiac arrest, and we have to consider the same protocol which we have followed in the cardiac arrest. Okay, so if we see the patient is in bradycardia less than 50 beats per minute, we'll straight away give atropine. We straight away give the atropine. Now atropine, the important thing is that atropine is always, yes, IV, and 1 milligram to be repeated every 3 to 5 minutes. 1 milligram to be repeated every 5 to 5 minutes. We can maximally give 3 milligram of 3 doses of atropine. Okay, so 3 doses of atropine we can give, and it is very important, it is 1 milligram bolus. It is 1 milligram bolus. It is not 0.5 milligram bolus. It is 1 milligram bolus. Okay, so there is some changes, so you should understand the atropine you have to give up to 3 milligram. Now still, if it is not effective, the bradycardia is not it's not done, we can go for transcutaneous pacing. We can go for temporary pacing, transcutaneous pacing. Why I am taking temporary? Because that we can just use it with your hands, right? So that is a different concept. Please go and watch your defibrillator and transcutaneous monitor. You have to understand. Okay, so go to your ICU, go to your emergency, look wherever, and you should know near your home or near your office which is the place which has the nearest defibrillator at least. Okay, in case of any emergencies to your known, you can use it, right? So transcutaneous pacing here is considered after ineffective atropine, transcutaneous pacing. Along with it, we can add dopamine or epinephrine. Okay, along with atropine, or directly after atropine is not working, we can go for dopamine or epinephrine IV infusion. The important thing to understand in the dopamine and epinephrine infusion is the dose. Now in dopamine, it is 5 to 20 microgram per kg per minute, but epinephrine is 2 to 10 microgram per minute infusion. Okay, so it is per kg, but it is not per kg. This is the only difference you have to you have to remember while you are remembering the dose of dopamine and epinephrine in case of bradycardia. Okay, and if you don't understand, we go for expert consultation, and there we get the permanent pacing or the pacemaker or the permanent pacing, that is the transvenous pacing. So this is all we have for bradycardia and bradyarrhythmias. Okay, these are the causes you have to consider, and these are the basic tachycardia or bradycardia. So we'll just repeat it once, that if a patient of tachyarrhythmias or bradyarrhythmias goes into cardiac arrest during our process, what we are going to do, we will straight away start CPR. If you see this pulse, we'll see the pulse, we'll activate the code blue team. Okay, we'll activate the code blue. Okay, and this code blue team will when they are coming, we'll start the CPR. We'll see the CPR. We'll start the compressions. We'll start the compression, and breathing will try to have a ratio of 30:2 in case of adult, right? In the 30:2. Then everything is attached. We know it is attached. The rhythm is shockable or not. Yes, we'll see the V fibrillation is there, ventricular fibrillation is there or not. We give a shock. Here the shock will be not less. It is the maximum we can give. There is 360 joules or 200 to 3. The maximum it gives, we give a maximum shock. The objective was to stop the heart and start again, right? To stop the heart and start the heart again, right? So that's the objective. So here the shock is maximum, but before we have seen in in synchronized cardioversion, we start from the lowest. I said you start from 100 and then you move, you raise ahead. ठीक है, you उसका एनर्जी जूल बढ़ाते रहो. ठीक है. So after the first shock, no medication. After the second shock we give epinephrine. The third shock we give amiodarone 300 है ना. फोर्थ शॉक वी गिव एपिनेफ्रिन अगेन बिकॉज 3 to 5 minutes. ठीक है. और एंड फिफ्थ शॉक वी गिव amiodarone 150 एंड द सिक्स शॉक वी गिव एपिनेफ्रिन. ठीक है. इस तरह से चलते रहेगा. ठीक है. इफ यू गेट अ नॉर्मल ECG रिदम बट देर अगेन नो पल्स, देन दिस इज नथिंग फॉर द पल्सलेस इलेक्ट्रिकल एक्टिविटी. वी गिव एपिनेफ्रिन एज सुन एज पॉसिबल, देन स्टार्ट फॉर द CPR. ठीक है. वी गिव एपिनेफ्रिन every 3 to 5 minutes. We see the rhythm is shockable or not. If it is shockable, again follow the same algorithm. ठीक है. If it is not shockable, we give a CPR. ABG तब तक आ जाएगा. ABG में अगर हाइपोकैलेमिया है या हाइपरकैलेमिया, उसका ट्रीटमेंट करवा दो. एसिडोसिस है तो उसको है ना बाइकार्ब दे दो. तो वट एवर द ट्रीटेबल कॉज इज, वी कैन ट्रीट इट एंड देन वी सी अगेन. नाउ व्हाट हैपन्स आफ्टर दैट? इफ द patient is come back to the return of ROSC is there, ठीक है, spontaneous circulation is there, what we see, then we go for the ABC management. ABC management we obtain a 12 lead ECG. ठीक है. and उसके बाद क्या होता है कि अगर patient you have to understand this is the patient is actually having some STEMI and problem, we go for the cath lab. उनको बताए थे कि आप अपना तैयार रखिए. ठीक है. we brief the doctor which is coming from the cath lab, from the cardio department. Okay. and we see the patient, if it follows the command, ठीक है, उसको कुछ नहीं करना है, उसको आराम से आपको अपना रिवर्सिबल कॉजेज को ट्रीट करते हुए उसको अपना आपको भेज देना है CCU. ठीक है. अगर वो हार्ट का कोई पेशेंट है तो. अगर फॉलोज कमांड नहीं कर रहा है तब आपको टेम्परेचर टारगेटेड मैनेजमेंट करना है, और आपको बताना भी है कि 24 आवर्स तक उनको 32 to 36 डिग्री तक हमको ये मतलब अटेंड करके रखना है. वो क्या कर सकते हैं? वी कैन यूज सम कूलिंग डिवाइस. ठीक है. आप जो पैड आता है ठंडा ठंडा, उसको आप आसपास रख के वो ठंडा रखना पड़ता है. ठीक है. टेम्परेचर बढ़ने नहीं देना होता है. सो ओके गाइज, थैंक यू. दिस वाज बेसिक ACLS. वट एवर आई हैव लर्न, आई हैव ट्राइड टू समराइज in these videos and the 2 videos which I have. So you can just go through it once, you can save many lives. Okay. So all the best. Bye.